So usually in Japan, so for the OAG patient, so because we have a lot of normal tension glaucoma patients, we will do the filtration surgery. So because the target pressure should be under 12 millimercuries. Also in exfoliation glaucoma, we will do the filtration surgery. Steroid glaucoma, canal surgery may be better compared to the filtration surgery at first. And traumatic glaucoma, inflammatory glaucoma, and neovascular glaucomas, for these secondary glaucoma, we will do the filtration surgery. So because the trabecular meshwork may be damaged by these original causes of IOP increase. So now we have a lot of options of the surgeries. In the upper of the figure, so this is a canal surgery. The original trabeculotomies and laser trabeculoplasties, viscocanalostomy, trabectome, canaloplasty, eye stent, these are all canal surgeries. And there is an option for the subchoroidal surgery, gold shunt. And the lower of this slide is filtration surgeries, trabeculectomy, non-penetrating, and express, and medial, aqueous, aquaflow, SK-GEL, T-flex. And there are many surgical options for the filtration surgeries. And in the orbiter, so we have a lot of glaucoma drainage devices. At first, canal surgery. So canal surgery to increase outflow is like this. Trabeculotomy and trabectome. So these are theoretically similar methods. And trabectome is easier than trabeculotomy. And the final pressure is around 15 millimercuries. And the eye stent, so this should be insert 2 stents to get a good pressure. So in the report, the final pressure is around over 16. And viscocanalostomy and canaloplasty increase outflow facility by expansion of the Schirm's canals. The target pressure of these surgeries are also high teen. And as you know, so laser trabeculoplasty is a transient effect to lower IOP. So we need to select dependent on the target pressure. So this is a trabeculotomy of internal using trabectome. At the tip of this handpiece, there is a coagulator, so we can ablate the trabecular meshwork tissues by the coagulation. So like this. We can approach trabecular meshwork up internal from the temporal side to the nasal side. The benefit of trabectome is intact conjunctiva. So we can keep the conjunctiva. So because we can insert these handpiece from the temporal cornea, and no scarring is quite a benefit for future filtration surgeries. And post-operative bleeding doesn't obstruct the open Schirm's canal. So because the cutting side is a nasal, usually nasal. So post-operative IOP spike or PAS may be less than trabeculotomy ab internal. So the original trabeculotomy, the bleeding is still inside, and also this may obstruct the Schirm's canals. And the intraoperative pressure in the anterior chamber can be maintained in the high level to protect the recurrent bleeding by the trabectome. So bleeding cannot be avoidable during and after trabeculotomy ab external. So this is the benefit of the trabeculotomy ab internal by the trabectome. The success rate by trabectome at 1 year is like this. So as you can see here, trabectome can get good pressure a good success rate. Even the target pressure is 15th. Japanese result is a little bit better compared to the worldwide. 70% success for target pressure under 15 millimercuries. And the IOP reduction is more successful in Japan. So anyway, we can get a good pressure by the thrombectomy of internal using the thrombectomy. Especially combined surgery with PAIOL is much better compared to the single thrombectomy. Also, thrombectomy is working for the exfoliation glaucoma. So thrombectomy can reduce IOP successfully in exfoliation glaucoma at least 1 year. So after this year, so sometimes exfoliation glaucoma have a higher intraocular pressure, but at this point, this is much better compared to the original method. So this is the eye stent. Eye stent is like a snorkel-shaped stainless device with 1 millimeter length and 120 micrometer diameters. So theoretically, one eye stent can expand around 180 degrees of Schrems canals. So this is one of the reports of the eye stent. This prospective study indicates successful IOP reduction from 21.5 to 16.9. And the medication score is 1.6 preoperatively to 0.4. So this is a minimal invasive canal surgery. However, theoretically, one eye stent is insufficient to lower IOP. So next is the filtration surgeries. So as you know, by the filtration surgeries, we can get a good target pressure around 10 to 12 millimercuries. And also we can reduce glaucoma eye drops. However, there are many complications. So this is the result of the trabeculectomy. So as you can see here, so after 6 months, so we can get a successful IOP reduction from the baseline. So the result is around 10 to 15 millimercuries. However, as you know, so bleb-related infection is a big issue in the trabeculectomies. So this is a Japanese study of the prospective incidence rate of bleb-related infection in Japanese glaucoma patients. In 5 years, 2.2% bleb infection happened by the trabeculectomy. Also, leakage is a high-risk factor of bleb infections. In 5 years, 4 times higher incidence in the bleb leakage. So we need to take care of these patients so not to occur the bleb infection. I want to introduce the express mini glaucoma shunt. This is a variation of the trabeculectomy. The procedure is almost similar. However, as you can see here, we don't need to do the peripheral iridectomies. So it means there is no bleeding in the anterior chamber and the inflammation is quite less compared to the trabeculectomies. So this is a recent result from the Redland, reported in the American Journal of Ophthalmology. Express implant versus trabeculectomies, 2 years result is quite similar.